Hello and welcome to the next episode of the Explain series with Dr. Bret. This episode will be focused on syphilis serology and explaining how to interpret what the syphilis results could possibly mean. There are a number of infections which are caused by the bacterium Treponema pallidum, and these infections will turn syphilis tests positive. These infections are called yaws, pinta and bejewel, as well as obviously the syphilis that we have come to know and love. And these particular diseases, yaws, pinta and bejewel, are usually found around the equatorial regions of planet Earth. And here's a picture of what it looks like. Now we do have a point of care test for syphilis, for early syphilis that is, and this is called the Darkground microscope, and under the Darkground microscope they look a little bit like this. You can usually get this type of point of care test done at your local sexual health centre, but only if you have primary syphilitic sores. And this can be seen in the first syphilis video which I did a couple of months ago. So in terms of interpretation of serology, let's imagine that you're a doctor and you see a 76-year-old man. He's brought in to see you by his son, who's concerned about progressive memory loss by his dad. And the doctor knows what test to send off, and it's just a simple yellow top SST bottle, and you just put on the laboratory form test for syphilis, and then after 5 days to 10 days, results are sent back to you. And the results will be reported exactly like this: EIA positive, TPPA negative, RPR positive. And then there will be a particularly unhelpful comment underneath that saying treponema infection unlikely, but please repeat to confirm. And you're there scratching your head thinking, what does this mean? Why the bloody hell did I even do the test in the first place? Well, syphilis serology is difficult. It's also confusing, and sexual health specialists often get it wrong. So why is it so difficult? Well, all of the serology tests can have false positives, and many give false negatives in almost any combination. Syphilis serology results can remain positive for many years after acute infection with or without treatment. And also syphilis serology tests can take 2 to 4 weeks to become positive in acute infection, and initial tests and if initial tests are negative and acute syphilis is still suspected, then we would advise that the tests be repeated for 2 to 4 weeks later. Obviously, if someone has history to go with it, you may treat them anyway. Or if they have syphilitic sores, then you can do the point of care test, which is Darkground microscopy. There's also other problems as well. Syphilis can mimic almost any disease, and it's impossible to interpret the results in terms of a clinical context, as theoretically anything could be syphilis. And what is referred to as syphilis serology tests are actually tests that are aimed at testing any treponemal infection. It could be yaws, bejewel or pinta. In fact, if you look on the World Health Organization website how to diagnose yaws, they advise you to do a TPPA test, which is exactly the same test you do for syphilis. And so all of these and all the tests we do, which we'll explain later, can give positive results, but it all depends on the different clinical situation, as also the history the patient gives as well. So the serological tests for syphilis are divided into treponemal and non-treponemal tests. Now the treponemal tests detect antigens or antibodies, and these tests are qualitative. What that means is either give a positive or a negative. Now the antibody test, which we usually use in the UK, but most of Europe and North America use it as well, is the EIA test, and I just call it the antibody test. The other test that we commonly do is the treponemal pallidum particle agglutination assay. That's obviously quite a mouthful, so we just call it TPPA. A similar test along those lines is the human agglutination assay, or TPHA, which is a bit more difficult to do, or the IgM or IgG immunoblot. Now, to be honest with you, the workhorse of syphilis tests are the EIA, or the antibody test, and the TPPA. And those are the most commonly used, and they are what I'm going to concentrate on. Now, in terms of the non-treponema tests, they are not specific. In other words, they could be positive for any particular reason. And what they do is they actually detect antibodies which react to cardiolipin, cholesterol, lecithin antigen, and that's in the serum of patients who have these type of infections. They usually carry around about a 2% false positive rate with these tests. Okay. Now, the old version of this test used to be called the vdrl, which is the Venereal Disease Research Laboratory Test. In other words, back in World War I and World War II. And you'd need a microscope to interpret the tests, because the reactions you would see under the microscope would be very, very faint. We don't do the vdrl test anymore. What we do instead is the modern equivalent, which is the RPR test, done in a similar type of way, but you can see it with the naked eye. You don't need a microscope. And the RPR stands for Rapid Plasma Regain Test. Now, the advantage of non-treponema tests is that they are qualitative and they could be used to monitor the response to treatment. And so the test will reduce with time and even become negative if the treatment has been successful. They don't always turn negative, but they will come down. The drawback with these tests is that the level will decrease anyway, and 50% of patients with latent syphilis may actually have a negative RPR 30 to 40 years after the initial infection, even though they have syphilis. So what you see here is a card, and you can see there are 5 circles, and we will call these circles wells, and WELLS. They're labelled 6, 7, 8, 9, 10. If you're wondering what happened to wells 1, 2, 3, 4, 5, it's just above that, but that was for another patient. Okay, and here it's labelled patient 1, 4, 7, and then you see a ratio going across 1 in 2, 1 in 4, 1 in 8, 1 in 16, 1 in 32. What does this all mean? What happens is a patient wants a syphilis screen, and so a syphilis test is done. The sample is spun down to push all the blood cells down into a solid lump at the bottom to leave some serum at the top. The serum at the top of the tube is taken out of the tube and then is put into a circle just before 6. Okay, and that would be what's called a neat sample. And then from that it will be diluted in half into the next well, which is well number 6, which is 1 in 2. It will then be diluted again in the next well, 1 in 4. It will be diluted in half again, 1 in 8, be diluted in half again, to 1 in 16, diluted in half again, to 1 in 32. And it keeps on going. So there is actually a further card, 11, 12, 13, 14, which goes from 1 in 32 to 1 in 64, 1 in 128, 1 in 256, etc., etc., etc. And it can go on. And then you then take the patient's serum, you then take the reagent and then you add it to each of the wells. And where you get a reaction, you get little clumps, and as we can see, in well number 6 it is starting to clump together, and the same has happened in well number 7, and so these are positive results, and so you're getting a positive reaction, and this happens in well number 8, and to my eye you're getting this reaction in well number 9, and so, but you're not getting this reaction in well number 10. It looks a little bit smoky. Okay, and so I would read this card as 1 in 16. Now, it's fine to disagree. Some people will say, well, actually, it's 1 in 8. And some people would say, oh, well, maybe it's kind of reacting in 1 in 32. Obviously, the further along the card it reacts, the stronger the positive test. Okay, and if you end up getting a reaction of 1 in 256, that's a very positive result. And that person has obviously got very, very active syphilis. So the RPR is a measure of how active and how strong the syphilis is in the body. I would say this is 1 in 16, and so it's positive syphilis. If the patient's baseline RPR was negative previously, then obviously 1 in 16 is a big increase. If the patient, though, has had syphilis in the past, has had treatment, and the treatment brought down his RPR down to a baseline of 1 in 2, then 1 in 16 would be a positive result. Okay. Obviously, in the future, he would get treatment again, and then in 3 months' time, we'll get another blood test to see if his RPR has come down, and another blood test 3 months after that, and then 3 months after that, and then a year after he had treatment. And it's important to monitor a patient's RPR to make sure they go back to their baseline. A lot of patients will actually go negative, but not all. So before we go on to other serological tests, in other words, the TPPA, and how to interpret all these tests all together, we have to look at how the difference between sensitivity and specificity of serological tests. Now, sensitivity tests measures the proportion of actual positives that are correctly identified as positives. In other words, how good is it at telling you something is positive? The specificity of a test measures the proportion of actual negatives that are correctly identified as actual negatives. In other words, if you get a negative test, is it actually a real negative test? And so this was a table I've pulled out from a paper from Park, Falke and Chow. It was published in 2019, and right at the bottom line it's got EIA, and this is effectively the antibody test, and its sensitivity, its true positive rate is quite good at 98%, but its specificity is not that good. And so if you get a negative test, you're only 82% sure. The TPPA test, which is the second line from the top, gives a sensitivity of 95. It's all right, I suppose, but the specificity is 100%. And so if it's negative, chances are it's a true negative. But you should also take that with a bit of a punch of salt. But what that TPPA means is it is a fairly reliable test. Okay, and the reason why I say you take it as a punch of salt, well, this will come clear in the interpretation of these three tests. So you've taken a blood result and you sent it to the lab, and the first result you get back on the top line, N is negative, NT means not tested, and R means reactive, okay, or a positive test. Now the EIA is negative. If the EIA is negative, then the patient has, syphilis is not detected, and so the other two tests are not actually done. Okay, if you think they are exposed to syphilis, then you can repeat the test in 4 weeks if clinically indicated. Obviously, if they have a partner who's told them that they have syphilis, then they should already be treated epidemiologically anyway. What happens if the EIA or the antibody test is returned reactive, but the other two tests are negative? What does that mean? Well, it could mean a possible early primary infection, or it could mean a false positive antibody test, or a very, very long-standing syphilis, either treated or untreated. So it gets a little bit difficult. So the antibody test could be reactive, the RPR could be active, but the TPPA could be negative. This could mean possible early primary syphilis or false positive antibody test and a false positive RPR. And if the antibody is positive, the TPPA is positive, but the RPR is negative, it could very well be possible long-standing syphilis, treated or untreated, or possible early syphilis with the RPR yet to become reactive. And the last one, they could all be positive, which could be possible current syphilis, treated or untreated, possible old syphilis, treated or untreated. But obviously, if the syphilis is old or treated, you would expect the RPR to be low. If the RPR is very high and they've never been treated for syphilis before, then you would obviously treat them. How do we resolve this complicated mess? Well, the most important thing is the history. I cannot stress how important it is. Most syphilis tests are actually uninterpretable without a good history from the patient, and that should include infectious disease history, travel history, especially if they've travelled from the equatorial regions of the planet to more northern or to the north or southern hemisphere, a sexual history and how many sexual partners they've had, if they're married and been married for a very, very long time, how many sexual partners their partner has had if they know, is it an open relationship, is it a closed relationship, and all these types of things. And sexual history is very important. You also need to do a full examination, including cardio, neural, and musculoskeletal. If they have good lesions on their body, you can perform a Darkground microscopy on. In other words, do they have a primary chancre? And watch the first 2 episodes of this in the syphilis series. Then you can do Darkground microscopy and see the spirochetes spiraling away under the microscope. In other words, doesn't matter what the tests say, they have syphilis. But you can't do that for a lesion on the mouth, because you can have common commensal harmless spirochetes in the mouth, which are not syphilis. Okay. You could also do a PCR test as well. If they've got a lesion, you can quickly do a little scrape on and then send that off to the lab. And then obviously serological tests. And serological screening, you could argue, comes last after you've considered all of the above. In terms of the treatment, there are many different regimes, and guidelines across the world have all these regimes. The most commonly used drugs are benzathine benzyl penicillin, 2.4 million units given intramuscularly. And a stat dose of 2.4 is given in early syphilis, and it's usually a lot of penicillin, so it's split into 2 doses, 1 shot in the right buttock, another shot in the left buttock. But if it's late syphilis, you get that dose weekly for 3 weeks. If you can't take penicillin for any reason, then doxycycline 100 milligrams twice a day can either be for 14 days for early syphilis or 28 days for late syphilis. But obviously, if it's a complicated syphilis like neurosyphilis, then that dose will be doubled to 200 milligrams BD for 28 days. And there are many, many other types of antibiotics you can use as well. The patient should always be warned of the Yerkes-Herxheimer reaction, and this is an acute febrile illness that comes with a headache, myalgia, chills and rigors. It feels basically like severe flu, and usually resolves within 24 hours, but can be so severe the patient can end up going to hospital because they're concerned for their own welfare. So it's very important you tell the patient about this, and sometimes we also tell the patient at 6 p.m. of an evening, you just take some paracetamol if you're getting any kind of reaction of any kind. So in conclusion, it doesn't matter if you're a patient, if you're a member of the public, if you're a medical student, if you're a doctor, you will encounter syphilis soon if you haven't already. And I mean this in your private life, if you're sexually active and have a recent change in partner, or if you are a medical professional. And if you're watching this out of interest and you are in cardiology or neurosurgery or something which you think has got nothing to do with syphilis, then you're probably not looking. Syphilis can be found in all patients, in all ages, in all specialties. And syphilis is a great mimic, and it always should always keep it in differential until it's proven otherwise. And if you're testing for syphilis, you should always test for HIV, and as well vice versa. If you're testing for HIV, you should also test for syphilis. In the UK, we always use gloves when we examine patients, and gloves are used all around the world, but just in case you're decided to do something a little bit weird and you're not using gloves, there was a paper done in the 1952 in extragenital syphilis in physicians, and so this was a bit more common to catch syphilis for people who didn't wear gloves. So obviously lesions of syphilis are infectious, and so the medical staff, doctors and nurses and other health professionals should be wearing gloves when they are examining patients, and obviously test regularly or at the start of a new relationship as well. So please watch the other 2 videos I've done regarding syphilis, and these are some of the websites I've used to put this episode together. So thank you very much. Please like, subscribe and share. And if you want to catch the World Health Report that's stopped from being shown on this particular YouTube channel, and that is now been put under another YouTube channel I run called World Health Report, and I just started that up, so feel free to subscribe to that one as well. Thank you very much, take care, and thank you for watching. Goodbye, and have good sexual health.